Melanie is a 55-year-old patient who has suffered from a spontaneous subarachnoid hemorrhage that required urgent surgery to stop the bleeding. She is now intubated and sedated and has been referred to me, a dietitian, for enteral feeding via an orgastric tube. She's on free drainage with minimal output and currently receiving IV fluids with 5% dextrose and 1/5 of normal saline at 70 milliliters per hour. To begin with, I will conduct a physical assessment of the patient. The patient appears to have adequate lean and adipose stores, and according to her partner, was previously fit and well, exercising most days. He has also told us that she is roughly 70 kilograms and 5'8". Whilst this is an approximate, it does seem appropriate as she appears to be in a healthy weight range, and these numbers give her a healthy BMI. Using this information, I can work out her estimated energy intake using Schofield's equation. I multiplied this by an injury factor of 1.2 due to the brain surgery and an activity factor of 1.3. This gave me 9,232 kilojoules per day. Her protein requirements were based on the general ICU protocol of 1.3 grams per kilogram, and fluid requirements were based on 35 mils per kilogram. From the information provided by her partner, I have gathered that she is not currently taking any medications and has no medical issues prior. I would check to see in the system if there are any other notes. The social history is based on the information provided by her partner that tells us that she is active and healthy, and this matches the information I gathered from the physical assessment I previously conducted on the patient. Looking at the biochemistry, I can see that she does not have any abnormal results and all are within the normal range. Upon physical inspection, I can also see that she has some mild lower limb edema. Her medications include phenytoin, which acts as a diuretic, and this can cancel out the need for fluid restriction. The edema will need to be monitored, however. The dextrose and free drainage should be stopped prior to commencing the feed. The energy provided by the propofol will need to be added as it is above 5 milliliters per hour, so it must be counted. The propofol provides 1,102 kilojoules of energy every 24 hours. As this is an active case, energy does not need to be complete. Just keep in mind that this is not long term and things can be altered once she is out of the medically induced coma. Melanie has not opened her bowels yet, however, this could be due to the propofol and will just need to be monitored. According to the asthma guidelines, in early acute ICU admission, the patient should receive 20 to 25 kilocal per kilogram. Using the 25 kilocal, the kilojoules required are 7,315 kilojoules. After minusing the propofol, this gives her 6,212 kilojoules. The GoldPro fiber at a rate of 50 ml per hour provides 6,420 kilojoules, providing enough to meet this energy requirement. The requirement based on the Schofield equation will need to be addressed once the patient is extubated. This GoldPro fiber feed provides 76 grams of protein and 960 ml of free water. The protein is close to her requirements, with the difference would be met once she is extubated, and the water requirements can be met with water flushes of 250 ml every 4 hours. The rate at which the feed is provided will start at 30 ml per hour and increase by 10 ml per hour every 4 hours, as long as there are no symptoms, until the target rate of 50 ml per hour is achieved. The nutrition diagnosis relates to the fact that the patient is not currently meeting protein and energy requirements due to the lack of oral intake from being intubated. While she is intubated, it is important to monitor for signs and symptoms of muscle wastage and worsening edema. The patient is extubated after day 8, and the speech pathologist assesses her and notes that she has a mild to moderate oropharyngeal dysphagia and recommends stage 5 ITSY diet with thin fluids using a straw and sitting upright for meals. A thorough assessment of the patient can still not be conducted as the patient is slightly irritable, suggesting it's not the best time to move her yet and she might not be in the correct mind frame to properly be assessed. Therefore, the weight, BMI, protein and energy requirements are still the same. The main assessment will be monitoring of the edema or muscle wastage and for any signs or symptoms that suggest a new course of action. New considerations, however, have arisen, including the dysphagia, which has determined the type of diet Melanie must now follow until a speech pathologist reassesses her and suggests otherwise. Melanie is of a healthy BMI range and doesn't appear to have lost a large amount of weight within the 8 days. However, as she has not eaten orally in the past 8 days, she might be at a slight risk of refeeding syndrome. This is not a major concern for her, but it will need to be monitored and we must watch for symptoms. She also has a temperature which should hopefully go back to normal, but we want to keep that in mind in case it spikes or isn't controlled, as that would require potentially more fluids and less food. As the patient is currently experiencing dysphagia and is only able to eat according to the speech pathologist's recommendation, there is a chance she will not be eating all the food she is being served. For this reason, it is crucial to monitor her food intake and watch for potential symptoms that she is not consuming enough. On day 12, Melanie is moved to the neurology ward, where she can probably be weighed and her biochemistry is reassessed. While she is still on the stage 5 ITSY diet, her condition is improving and her biochemistry results are unremarkable. Her new weight recorded 65, which while it is 5 kilos lighter than previously recorded, it must be noted that the previous weight was an approximation from her partner, so may not have been exact. A small amount of weight loss can also be expected from her time in the ICU and on this diet. I'm not worried as she is still in the healthy weight range. New requirements have been calculated, however, to better suit her current weight. This slightly decreases her protein and fluid requirements. It is important to educate Melanie on her new diet for the time being, as she will be continuing it at home. Her comment on not enjoying the pureed fruit is another consideration that can be met by talking to the staff about offering an alternative, as we want her to be encouraged to eat all that she is given, and also by offering her alternatives for when she goes home. The main consideration for Melanie is now an education regarding the new diet for the time being. Therefore, the new nutritional diagnosis is food and nutrition related knowledge deficit related to the prescribed diet, as evidenced by the fact that she hasn't been on a diet like this before, and we want to make it as easy as possible for her to be able to stick to it when she leaves the hospital. Education I will provide for Melanie for when she goes home will be mainly around ensuring she sticks to the ITSY diet whilst eating enough to maintain her weight. This includes defining what the diet is, checks she can make, ways to make the food more moist, foods to avoid, and recipes that she can use.